Thank you very much, sir, for giving me an opportunity to present at this forum. Mine would be a practical approach rather than extensive details about the angiogram and OCT. So, as we know, the traditional methods for imaging for any retinal vascular diseases is stereoscopic fundus photography, as elucidated by Dr. Sunil, and fluorescein angiography have been the historic gold standards for imaging retinal vascular diseases. So the types of machines which are available for doing fluorescein angiograms are the conventional angiogram on the left of your screen, and the HRA based systems, that's the confocal SLO based systems on the right. So the importance of angiogram in diabetic retinopathy is more so in case of diabetic maculopathy, because the judgment of NPDR and PDR is more clinical. So how does FA helps in diabetic maculopathy? It guides us to treat the diabetic macular edema. It guides us to know the extent of macular non-perfusion. Suppose we are evaluating an unexplained visual loss, we should first rule out ischemic maculopathy. These days of OCT, we are always ruling out a VMT, but we should bear in mind that ischemic maculopathy is one such cause of unexplained visual loss in these patients. The effect of treatment and whether further supplementation of laser for macula is required or not can be assessed with the help of angiogram. So this is an example of focal diabetic macular edema on a standard fundus photograph. This is how it looks as an angiogram. You see focal hyperfluorescent spots close to the macula in the early phase, and by late phase you see those leaking microaneurysms causing focal exudative diabetic macular edema. So this is the focal diabetic macular edema angiogram. Then comes the diffuse diabetic macular edema and the CME component, where you see multiple hard exudates on the standard color photograph, and where you see diffuse leakage from the microaneurysms and finally causing ascistoid macular edema. This is diffuse diabetic exudative maculopathy. So this is the early stage picture, and this is by late stage where you expect pooling of the dye in those cystic spaces. This is typical cystoid macular edema with diffuse diabetic macular edema. And the standard of care had been a grid laser for diffuse diabetic exudative maculopathy, but nowadays the management has changed. So this is an angiographic picture post grid done in older times, where you can see these hyperfluorescent borders with hyperfluorescent central spots suggestive of grid laser scars. So, and to highlight the cause of unexplained visual loss on an angiogram in a rather subtle looking diabetic retinopathy or maculopathy case, here you can see a retinal vascular filling defect where you see enlarged foveal avascular zone and a distorted foveal avascular zone. So this is a case of ischemic maculopathy, again demonstrated very well on a HRA system. Then what is the importance of angiogram in non-proliferative and proliferative diabetic retinopathy? It differentiates us from the IRMA when we are in clinical suspicion whether it's an IRMA, as pointed out by Dr. Sunil, which runs between the major vessels, or it's a subclinical NV or clinically obscured NV. Then angio has a role, though mostly the diagnosis is clinical, and it identifies the persistence or increase or regression of neovascularization elsewhere or this. What you treat by making a clinical diagnosis, you treat the very severe NPDR or PDR component with pan-retinal photocoagulation. But still, if you're not happy, or if there are some minor bleeds, you can always repeat an angiogram to notify whether there's any persistence or increase, or whether there is regression as well. So this is one picture on the extreme left of your picture, where you see a big neovascular front with some fibrous proliferation which can't be missed, which is clean, which is seen equally well on an angiogram. Which PDR can have an associated maculopathy as well, that should be anyhow remembered. These are other examples where you see massive capillary non-perfusion areas, the capillary drop-out areas, which are not usually picked up on clinical photographs. So sometimes we see massive capillary non-perfusion areas, which suggests that there is an increased VEGF activity there, and that it would be prudent to do a laser even if there are no neovascular elsewhere. So, and coming to an example of blocked fluorescence in diabetic retinopathy, if you see a subhyaloid hemorrhage or a vitreous hemorrhage, that will cause a blocked fluorescence. So we have to be careful whether the blocked fluorescence is due to a massive hemorrhage like this, or could be a small subhyaloid hemorrhage at the macula, and you might think that it is ischemic maculopathy, and it is not. So it is blocked fluorescence from subhyaloid hemorrhage. So coming to a featureless retina or a silent PDR, you might see this picture being a relatively innocuous fundus photograph. But when you do an angiogram, this is a montage view of the same patient, where you see multiple neovascularization elsewhere, and also capillary dropouts in the periphery. So, and also angiography is used to judge the adequacy of PRP if you are not happy or the patient is not happy, if you see some clinical activity going on, this is prior to PRP, this is post-adequate PRP. After few months, maybe 4 to 5 months, you can do an angio if you want to and can see whether the PRP is adequate or not, particularly if it is a single-eyed patient. Sometimes we can find this way that though we have done a tight PRP, the PRP is not adequate, so this is an angiogram picture of a post-inadequate PRP. So coming to now, because the era of anti-VEGFs, what role does an angiogram has in anti-VEGFs? At least I have studied the role of angiogram by using anti-VEGFs in PDR and diabetic macular edema. This is what a few studies have to say. A single intravitreal bevacizumab has achieved a reduction of fluorescein leakage from persistent NV refractory to PRP without vision loss. So whenever you have done an adequate PRP and still some new vessels are showing up and you don't have no more areas to fill in the periphery or do an additional peripheral cryo as well, then it's prudent to consider an anti-VEGF. So coming to the newer kid on the block, that is the wide field angiogram, ultra wide field angiogram, which stands 200 degrees of the field, which covers 82.5% of the retinal surface area. So this is the wide field imaging. What extra help does it give in the area of diabetic retinopathy? Yes, as said by Dr. Sunil, 7 standard fields have been shown on the standard photograph, but in ultra wide field angiogram you can still see that the central part is fine, but in the periphery you can see new vessels, sort of new vessel activity going on and few laser scars. So this has an edge, but we have to balance between the cost as well. So what difference does it give between the conventional and ultra wide field angiogram? As here you can see very few areas of activity, but here you can see a lot of CNP areas. This is the comparative photographs left and the right, the conventional versus the ultra wide field fundus fluorescein angiogram. So coming to one more important application is the peripheral ischemia. Despite treating the maculopathy and the retinopathy very well, sometimes we feel that it's inadequate, but you see a lot of peripheral capillary dropouts. So this ultra wide field angiogram gives a good insight in this peripheral ischemia. Then there is a concept called targeted retinal photocoagulation. This targeted retinal photocoagulation, we can target the peripheral CNP areas by which we can even hinder the retinopathy as well as we can augment the response of anti-VEGF. Even the macular edema can get better with peripheral treatments. So this is a peripheral laser to augment the intravitreal bevacizumab response in a case of cystoid macular edema. So coming to OCT, these are the patterns we see in OCT. This is the standard teaching, exudative macular edema, either a spongy type or a cystoid type, or it can be a serous macular detachment. There is a subsensory serous fluid collection, or it can be a vitreomacular traction or adherence or adhesion, or a taut posterior hyaloid and a tractional retinal detachment. These are the patterns we need. But with spectral domain OCT, we know the importance of external limiting membrane and ISOS integrity is very important to assess the final visual outcome post-treatment. So just a few slides about the OCT. This is the standard spongy macular edema in case of diabetic maculopathy, where you see increased macular thickening subfoveally and you see those hyper-reflective areas or the hard exudates. And this is for that spongy macular edema, pre-laser diabetic macular edema, pre-laser spongy diabetic macular edema. Post-laser you can see there is a decrease in thickening, as you can see there. So coming to the next pattern, cystoid macular edema, where you can see cystoid spaces and you can see some septae also between. So this is another pattern which we see commonly on OCT. So this is another picture of the cystoid macular edema, where you can see on the spectralis, where you can see a beautiful demonstration of the cyst and the septae. And then the third pattern is a subsensory fluid, that is the serous detachment, where you see an area of hyporeflective area with very little noise beneath the neurosensory retina. So then there is one more pattern where the vision is too less. You see a clump of hard exudates at the fovea. Here this is that picture where you see this is a collection of those clump of hard exudates. So this we can't do much except for systemic control. Then the final pattern, vitreomacular traction, the anatomical factors, that's vitreomacular traction. This is a very important tool to assess the cause of unexplained visual loss, where you have not seen any ischemic maculopathy, you have not seen any pale disc or AON, but the vision is very poor. Probably you have a vitreomacular traction. Stop treating the macular edema parts, treat the tractional part with surgery. So this is a pre-op and a post-op picture of the same. And final, the foveal tractional retinal detachment, which you obviously can't miss. It's a clinical diagnosis, but sometimes it could be so subtle and one-eyed situations and all, then OCT could be a good tool to assess a foveal tractional detachment. And these days of anti-VEGF era, the next speaker is going to cover, this is how an OCT can be used serially, maybe twice every bi-monthly, so that we can follow how good the macula behaves with anti-VEGF treatment or with steroids. This is how it translates on OCT. So coming to just a few words on the latest OCTs, time domain OCT has a little disadvantage because only less than 5% of macula is covered in a single image set because we use radial lines. In a spectral domain OCT, it is 100 times more faster than the time domain OCT, and it requires 4000 A scans per second. So spectral domain OCT gives more details. This is how it is shown very well. As you can see the clinical picture, you can see only a clump of ardextrates, cercinates and probabilism, but here it reflects very well on the spectralis where you see anatomical factor. So the few points on the latest OCTs. This is enhanced depth image OCT, which is also available on the spectralis, no financial interest. So it can give you the choroidal details as well. Most of the studies come to a conclusion that there is choroidal thinning, there is of advanced diabetic view the choroid. So there is one more OCT software called Swift Source OCT, where it is 10 times much faster than the available spectral domain OCT machines, where you can visualize the deeper structures better. And finally, Doppler OCT, where you can record or quantify the vascular abnormalities of the retina and choroid. And N-phase imaging, where you can delineate individual structures as well, like GCL vessels, internal limiting membrane capillaries. And then came the adaptive optics, where even visualization of individual photoreceptors segments can be made. Thank you for your patience.